Hello, I'm Dr. Claudia Chou. I'm a hospice and palliative medicine physician at Mayo Clinic in Rochester, Minnesota. I'm here to talk about the role of hospice and palliative medicine in MSA. I have no disclosures. The objectives are to define hospice and palliative medicine and to discuss the role of hospice and palliative medicine in MSA in relation to symptom management, advanced care planning, and caregiver support. So what is palliative medicine? It also goes by palliative care, and we can talk about that in a little bit. It is a team-based model of care for patients with advanced or progressive illness. It focuses on providing relief from the symptoms and stress of that illness through preventing or relieving suffering. Palliative medicine is made up of a number of core team members, which really makes it a multidisciplinary approach to care. These people can include physicians, nurse practitioners, physician assistants, registered nurses, social workers, and chaplains. Now, palliative medicine is a term that many people may not have heard of before, and there may be a lot of anxiety and worry associated with meeting with palliative medicine for the first time. It's usually helpful to review a few key points to begin with. Palliative medicine is multidisciplinary. It is patient and family centered, and it does focus on quality of life. It is not akin to giving up. It is not the last resort just because there are no other options available, and it is not the same as hospice. Now, I'd mentioned palliative medicine may also be called palliative care or supportive care. Really, these are all terms for the same team of people who have the same goals. It really may just be a difference of which institution you're seeking care through. The goal of all of these teams is to improve quality of life for both patients and their care partners. We understand that quality of life means different things to different people, and so our goal is to figure out what is most important to you. So I've talked a little bit about the fact that palliative care is different than hospice. So what is hospice? Hospice is continued whole person care through the last phase of life. That generally means it is for a patient who is in the last 6 months of their life, as far as we can estimate based on our knowledge of the patient and our knowledge of the disease process. We realize that no one can predict the future with any certainty, and so this 6-month prognosis is really more of a Medicare guideline. We certainly have patients who live beyond that 6 months, and they can still remain on hospice as long as we anticipate that they will continue to decline and thus remain hospice eligible. Hospice is for patients who are no longer seeking curative or disease-directed therapies, or for patients in whom further therapy is not an option. I know that can be a little bit confusing too, knowing that there are a lot of diseases, often in neurology, that don't have any curative options available right now. In our patients with cancer, certainly this can make a little bit more sense if chemotherapy or other sorts of cancer-directed therapy are not being offered. For our patients with neurologic disease, this often means that they are no longer at the point of seeking further clinical trials. It may mean that even routine visits to primary care are no longer thought to be helpful, or they might be more burdensome than helpful. It is for those patients who think that even in case of sudden decline, where one would ordinarily call the emergency department, our patients are thinking that even that might be more burdensome than helpful and detract away from their time at home. Hospice does bring team-based care to where patients call home, whether that's in their own individual home, in an assisted living facility, or a skilled nursing facility. Certain types of hospice cares can even be carried out in the hospital setting. Our patients on hospice have access to the hospice team 24 hours a day, over the phone, and sometimes even in in-person visits. The philosophy of hospice is that we are adding life to days as opposed to days to life. Hospice is comprised of a number of team members as well. This includes physicians, who may be called the hospice medical director, nurse practitioners, physician assistants, registered nurses, social workers, counseling in the form of spiritual care or chaplaincy, dietary or bereavement services, pharmacists, volunteers, and hospice aides. So when is the ideal time to involve palliative medicine? Palliative medicine is really based on a patient's needs and not their overall prognosis. And so if a patient has needs in terms of symptom management, decision making, or support for themselves or their loved ones, then it is a perfectly appropriate time to consult palliative care, even from the time of diagnosis. We can provide care alongside patients who are seeking curative treatment as well as clinical trials. Why does palliative medicine make sense for patients with MSA? Well, we recognize that neurologic conditions, including MSA, tend to have a high symptom burden. We know that MSA has a variable disease course and it changes over time. Every patient's course with MSA may look different, and even within one patient, there are going to be periods in which they have different symptoms, the symptom burden is higher, things may feel like they are in a place of stability, or things may feel like they are progressing more quickly, and we can help navigate all of those challenges. MSA patients may be faced with difficult decisions regarding their care. And we know that MSA affects not only patients, but also their families and their caregivers. So what could palliative care offer you? We really think that we would offer a symptom assessment with treatment recommendations and management, coping, counseling, and assessment for caregiver distress, and help with advanced care planning. We really have that 10,000-foot view. In terms of symptom management, what might this look like for a patient with MSA? We recognize that pain and other distressing symptoms can be a part of serious illness. We talk about the experience of living with MSA. How are things going on a day-to-day basis? What are the things that are most difficult about this disease? We recognize that illness affects someone's spiritual and emotional health as well. And we offer a support system to help patients live as actively as possible for as long as possible. My patients with MSA recognize that there is a large symptom burden that comes along with MSA, and certainly a lot of those symptoms are physical. They may be talking to their neurologist about a lot of these symptoms and talking about different medication strategies. They may be speaking with physical medicine and rehabilitation about physical therapy, occupational therapy, and speech therapy. They may be thinking about adaptive equipment. They may be seeing sleep medicine or urology. We recognize that the care of MSA is complex and really takes a multidisciplinary approach. Even though we recognize that the symptom burden in MSA is very high, a lot of those are physical symptoms, and patients are certainly made up of more than just their physical bodies. We recognize that there is the spiritual self as well. Where does someone fit into the greater world? How are they coping with their disease, and what might happen next? These are perfect questions for our palliative care chaplains. We recognize there is a psychological toll that comes with serious illness. Depression and anxiety are very common in the general population, and certainly these can worsen when we are living with serious illness. Patients and caregivers may need to think of different ways of coping with their illness. They may need to think about looking at our social work resources, thinking about individual or family therapy or counseling to work through some of these issues. We recognize that there is the social and practical aspects to life as well, and none of those stop just because we're living with a serious illness. Our schedules continue on. There are always appointments to happen and bills to be paid. We recognize that social relationships may change as well. Some friends may become closer and some may pull back. Social engagements may become more difficult. A lot of patients really identify work as being very important to themselves, and many are not able to keep working in that way anymore. That can be a loss of community and some form of purpose. We recognize that hobbies can change as well. So there certainly are a lot of losses that come along with serious illness. Finally, we recognize that there are issues of coping, counseling, and caregiver distress. I mentioned this a little bit in that psychological realm on the previous slide, but of course the effects of serious illness extend beyond just the patient, and we try to offer a support system to help family cope during the patient's illness. We can talk too about planning for the future. It's difficult to give an individual a prognosis, and we expect over time that all patients will require more help with mobility and daily activities. And it's important just to begin to start to think about who might be able to provide that extra help and where that will occur. Are there family members who may be able to move closer or even into the home to help provide that help? Would we be thinking about external sources of help, such as paid caregiving, or even moving out of the home into a sort of care facility? This brings us to the topic of advanced care planning, and this also goes by the term advanced directives. This gives patients the ability to appoint a healthcare agent to make healthcare decisions for themselves if they cannot speak for themselves or cannot decide. As long as our patients are able to talk to us and understand what's going on with their healthcare and express a choice, then we will always turn to our patients first. However, we recognize that involving family members can be very important at certain points in a patient's disease. Advanced care planning allows patients to state their wishes about the type of healthcare they want and share those wishes with loved ones and the medical team. As hard as these conversations are to have, it's easier to have these conversations when a patient is feeling relatively well and can participate, rather than when they're in the midst of a health crisis. I want to emphasize that this is not a single conversation, but this evolves over time. Planning ahead can be a gift that our patients give to their loved ones by outlining their wishes and giving a plan to be followed through. Some patients might complete advanced care planning alongside other legal documents, such as a financial power of attorney or wills. This all falls under the scope of estate planning, which can be done with an attorney. However, for the medical aspect, it may be important to still continue to talk about the healthcare aspects of this paperwork with a healthcare professional. So how do you complete your advanced care plan? Of course, there are a significant number of factors, including the state in which you live. There can be variability in the different forms and the different questions that are asked on the forms. At a minimum, naming a proxy decision maker is vitally important while a patient is still able to make medical decisions. Forms may require a notary to sign them in order to make them legal. They may require witnesses, so read your individual form carefully to make sure you're filling it out correctly. And you can discuss those medical aspects with your neurologist, your primary care physician, or with palliative care. There is one document that extends across a number of states and at last count was legally valid in 36 states, and that is the 5 wishes document. You can Google this online. There is a cost with ordering the document to come to your house, but we found that this is very helpful in breaking down some of those big questions that are asked in an advanced care planning document. This allows you to name a surrogate decision maker. It allows you to talk about the kind of medical treatment you do want and also protect you from the type of medical treatment you don't want. It talks about how comfortable you want to be, how you want people to treat you, and what you want your loved ones to know. I often tell my patients that this is starting a conversation and that this evolves over time. We recognize that there are difficult decisions that may need to be made in a patient with MSA. Commonly, these can include decisions around a feeding tube, which is also known as a PEG tube or a gastrostomy. For patients with breathing difficulties or a stridor, we may be talking about a tracheostomy or a surgical airway. I want to emphasize that these are deeply personal decisions for each individual. This often requires multiple discussions with the medical team and loved ones about what life might look like with these interventions. How will day-to-day life change? We encourage our patients to learn from the experiences of others. Our patients are wonderful teachers for us, and they're wonderful teachers for the community as well. Organizations like the MSA Coalition will have resources to help talk you through some of these decisions. Learning from other patients with MSA or others who have gone through similar decisions in the past can be an invaluable source of support and information. We also talk about a patient's place of care in terms of difficult decisions, and sometimes that means a transition out of the home setting to a place where they can receive a higher level of care from trained staff. Our care transitions can occur to places like assisted living, long-term care, and hospice, with different levels of support offered at each one of those levels. Now, I brought up hospice, and I wanted to talk a little bit more about hospice, just like I had talked a little bit more about palliative care earlier. When I bring up hospice, I hear some common concerns, and so I wanted to address those here today. I've heard that hospice does nothing, and I would say that hospice believes that patients and carers deserve whole person care through the end of life. So just as in palliative care, we thought about the spiritual self, the psychological self, and the social and practical needs, we continue those cares in hospice, helping patients walk through that phase of life. I've heard that hospice takes all of your medications away. And in my practice in hospice, hospice will help figure out what meds are truly necessary to control symptoms and promote comfort. My patients on hospice are at the point in which comfort becomes the primary goal, and so it's worthwhile to look at the medication list again and really keep only what's necessary. I've been told that hospice only gives you morphine, and I would say that morphine is one of a number of medications that could be used to promote that comfort. And we only dose medications to reach a certain level of comfort, which is the patient's desired level of comfort. So our goal is not to speed up or slow down the natural dying process. Hospice means there's no hope. And I would say that for my patients on hospice, cure might no longer be possible. But we help define what other types of hopes there might be, whether that's comfort, time with family, or being at home. Hospice can help meet goals in that way. So my patients will often ask me, is hospice right for me? Is this the path forward? And I would say we need to take a step back and look at the bigger picture. Again, working with a medical team that knows the patient well, that knows their values and preferences, or can ask questions about their values and preferences regarding their care. Working with a medical team that knows what MSA might look like, and really asking questions to see if hospice is the right fit. It's usually not just a yes or no answer, but it's a conversation. And so I wanted to end with how to even get access to these resources. How do we get palliative medicine? I would say start by talking to your loved ones about your wishes. Start to document the things that are important to you as you think about your care. That's something that can happen within a palliative medicine visit. That's something that can happen outside a palliative medicine visit. If you wanted to see a palliative medicine specialist specifically, I would say start by talking to your neurologist or primary care provider. There may be local palliative clinics in your area. When it comes to that point where you might be thinking about hospice, my patients might ask me, how do I get to hospice? Well, we would say you can talk to your neurologist and our primary care provider first and foremost and say, do you think hospice makes sense at this point in my disease? They should be able to give you a sense of what they have seen about your disease, what they have seen other patients go through, and again, put that in line with your wishes and preferences. And that brings me to my next point. Talk to those who know you best. Knowing that hospice is a form of care that focuses primarily on comfort, are we at that point where comfort is our number one goal? I did link here to the Medicare Hospice Finder, and honestly, just putting this into any search engine will pull that up. Medicare Hospice Finder will bring you to this website via Medicare where you can put in your zip code or your city and pull up a list of the hospices serving your geographical area. Hospices tend to be very geographically based. Patients can also self-refer to hospice and just talk to a hospice about what their wishes are and perhaps have a meeting face-to-face to discuss more if hospice is the right fit at this time. I did want to mention some other resources. We talked about the MSA Coalition, and then we also have some more palliative care specific resources. Get Palliative Care is a great resource. Through Caring Info, you can look for your state's specific advance directive form. I'd mentioned 5 Wishes before. And we have a newer society called the International Neuropalliative Care Society, which aims to be a resource for palliative care in neurologic disease for all patients, all providers, all care partners, and all advocates. So it's a lofty goal, but they are working on being that resource. I wanted to say a huge thank you to Dr. Laura Ree, who is one of my palliative medicine physician colleagues. She and I put this talk together a few years ago. Dr. Elizabeth Kuhn is our MSA neurologist. We are well supported by our neurology nurses, Tricia Stevens and Carrie Nagel. And then I wanted to thank you all, the patients, care partners, and MSA Coalition who make our care possible and for whom it's a privilege to serve. Thank you so much.